Let's take a look at a document from CGS, which is my Medicare MAC. This is Outpatient Physical and Occupational Therapy Services L34049. I want to go to the section that talks about skilled therapy. I'm going to have the computer read sections of that, and I want to talk to you about that and provide some perspective on it. So let me go ahead and share my screen. Let's just start right here with this first paragraph. I hate reading, so I'm just going to let the computer read it.
A service is not considered a skilled therapy service merely because it is furnished by a therapist or by a therapist/therapy assistant under the direct or general supervision, as applicable, of a therapist. If a service can be self-administered or safely and effectively furnished by an unskilled person, without the direct or general supervision, as applicable, of a therapist, the service cannot be regarded as a skilled therapy service even though a therapist actually furnishes the service. Similarly, the unavailability of a competent person to provide a non-skilled service, notwithstanding the importance of the service to the patient, does not make it a skilled service when a therapist furnishes the service.
Okay, let's just talk about these two run-on sentences for a minute. If a service can be self-administered or safely and effectively furnished by an unskilled person. Now, my question to you, and this is a genuine question. Well, we know the skills of a therapist are required to perform the physical therapy evaluation. No doubt. We know the skills of a therapist are required to establish the plan of care to determine goals that are appropriate for the patient based on the clinical findings from the evaluation. I would even say the skills of a therapist are required to teach, to educate both the patient, the caregiver, the family of the patient in what needs to be done. But at some point, where do we draw the line to say, okay, I've evaluated you, I've determined what you need to do, I've shown you how to do it, or I've shown your family or caregiver how to do it, and it can be done. Now what needs to happen is you just need to do it. I think that's the line that distinguishes between covered services and non-covered services. And I think this, along with the second sentence behind it, reinforces that reality, which is if I have a patient who they've been deconditioned, they've got some neurologic degenerative condition that's going on. Maybe they have frequent falls, maybe they have some back pain, hip pain, knee pain. And ultimately, as the evaluating therapist, I determine, okay, I can slow the decline, maybe improve some function. I need to educate, I need to inform, but at some point, the patient just needs to do it. I think that is the point at which covered services is no longer a benefit, and we need to either discharge or transition to self-pay. And then as it goes on, it says, similarly, the unavailability of a competent person to provide a non-skilled service, notwithstanding the importance of the service to the patient, does not make it a skilled service when the therapist furnishes the service. That sentence is so powerful because what that tells me is it says, okay, I've evaluated you. I know that you're capable of doing it, or you're not capable of doing it, because that's an evaluation too. And you don't have somebody here to help you do it. We're done. There's nothing else that I can do under the Medicare covered benefit policy, because this is not a covered service once we've moved past that line. What are your thoughts? This is one of those things that I think frustrates therapists because we feel like our hands are tied. We feel like we don't know where we end. We know that the patient wants more services. We know that the doctor is happy to write another referral. But at the end of the day, we are the ones making the determination, assuming the financial liability based on the decision that we make. We are ultimately responsible.